Good morning to us all. Welcome to this webinar. My name is Solomon Nakawesi. I am going to be a moderator for the next 2 hours. Thank you for making time to be with us today. I know there's so many things that are taking your time. I know there's so many webinars, but also I know there's so much difficulty, anxiety, but also trying to reposition in the new normal. On behalf of the Coalition to Stop Maternal Mortality Due to Unsafe Abortion, SRHR, I'd like to welcome you all to this webinar. It's the first series of webinars for SRHR, and the topic that we are going to have today is a resilient sexual and reproductive health and rights movement in the face of COVID-19. We're going to have a very lively conversation today between 10:30 and 12:30. And we are going to have this conversation because as a coalition, we would like to have deeper reflections on the various measures that the government of Uganda is undertaking to fight the pandemic, but at the same time to ensure that as we're fighting the pandemic, we are not losing the gains that we've registered under SRHR, but also to surface key issues under SRHR that for long we have been engaging with, but probably did not have a lot of attention that was required. And therefore, this particular webinar is going to discuss the current state of SRHR in Uganda with the objective of really building a resilient coalition that responds to the implication of COVID-19 and ensures sustainability of SRHR gains in the past few years. But before we delve into that, I'd like to take us back to the basics. What is sexual and reproductive health and rights? Most times we kind of conflate or mix a number of things. Under sexual and reproductive health and rights, we have a combination of 4 fields or areas of work and a lot of work. We have sexual health, which is basically a state of physical, mental, social well-being, which is not merely the absence of disease, but really around sexual health, hygiene, the functions, the systems that we have there in various stages of our lives. And then we have sexual rights, which I would like to really recall the Declaration on Sexual Rights and the Yogyakarta Principles, which is really about a person's integrity, the right to your sexuality, including a spectrum of sexual and reproductive health and rights, but also across the spectrum of sexual orientation, gender identity, and expression. And then we have reproductive health, which of course the WHO defines as people making informed decisions, having to having effective, appropriate healthcare services for education, and also making sure that choices, and also for women to go safely through pregnancy, but also to make a decision whether they keep a pregnancy or not. And then reproductive rights, this is a component that is really around the legal rights relating to reproduction and reproductive health. And these ones, of course, vary across space and geography. And basically, it's where individuals decide freely, without coercion, without discrimination, without violence, the basic right of if they want to have children, how they want to have them, the spacing they want to have, whether even not they want to have children, and also to have a high standard of sexual health and reproductive health, irrespective of their choices, of their social class, and life choices. So with that, one of the things that we really like to see is for us to have a panel that helps us really look at resilient. And we have none other than the best panel out there. We have one of the people we call the key feminist witch of the continent, Hope Chigudu, who is going to give us a keynote address. And then we have Dr. Carol Sechimpi of Maristops, who's going to give us a panel presentation on SRHR priorities and how they've been impacted. We also have Dr. Charles Chigundu, who is on the front line, who amidst when we're all home and hiding away from this COVID-19 virus, they were at the forefront. They had to still continue providing services. And then we have Dr. Agnes Nyamato, who brings in a component of the regional SRHR provision, what has happened, but also post-COVID-19, what will happen when the virus goes away, or when we get used to it, or when things get back to whatever we call normalcy, what are we going to do in terms of SRHR? And then Asia is going to really take us inward in terms of the opportunities and challenges, but also in terms of where is our future around SRHR advocacy. I'd like to take this humble opportunity to invite the keynote speaker to tell us who they are, and then thereafter the panelists tell us who they are, and then you can start our engagement. Thank you very much and welcome to this webinar.
Thanks very much, Salome. You've introduced me as an African witch. Actually, I was witching at 3. Okay, you've introduced me as an African witch, but you know, I see myself as, I call myself an African feminist, Pan-Africanist, and usually I introduce myself as a servant of women. When they ask me to jump, I just ask how high. I live in Uganda and Zimbabwe, and you know, over the past 20 years, I've witnessed many epidemics, and I'm very, very happy to be here and share what I know and learn from you as we move forward. Thanks very much, Solomon.
Thank you, Hope. Welcome on board. Dr. Carol.
Thank you, Salome. As you said, my name is Dr. Carol Sechimpi. I head the Maristopes Country Program in Uganda. I am a public health specialist, and really for me, that is the drive behind my work. More importantly, I'm a mother of girls, and I'm a proud Ugandan. I'm excited that we're having this conversation, and I look forward to making a meaningful contribution. Thank you.
Thank you very much. Welcome. Let's have Dr. Chigundu. Dr. Ernest, are you there?
Yeah, yes, I'm here.
Please introduce yourself.
Good morning. My name is Dr. Ernest Nyamato. I'm also a public health specialist with focus on reproductive health and rights. I am a Kenyan. I am the director for IPAS Africa Alliance. We support programs both in Kenya and Uganda, and it's a pleasure to be here.
Welcome, Dr. Ernest. Let's have Asia.
Good morning, everybody. My name is Asia Russell. I'm the Executive Director of Health Gap. I'm based here in Kampala, and Health Gap is an activist organization. We collaborate with all of the amazing members of SISMUA to share our skills in campaigning, in building effective activist strategies and deploying effective activist tactics together, because our analysis is that without deploying power, we never win the progress that communities demand around sexual and reproductive health and rights. It takes more than evidence, it takes a movement. It's a pleasure to be with everybody today.
Thank you, Eze. Dr. Chigundu.
This opportunity. I am a doctor. I work on like you said, at the front line, section productive health service provider. Will be sharing with you shortly, and I'm also delighted to be sharing with the regional people that have a regional touch to this. That probably will make us understand that COVID and its challenges are not necessarily only in Uganda, but probably a little bit beyond. I'm delighted and I'm happy to participate.
Thank you very much. Welcome, Doctor. And apologies to your clients that are in the hospital waiting for you, but you're here with us on the call. You'll have to agree with me. We couldn't have a better panel than this to talk about SRHR. First of all, we're all having our microphones muted purposively so that we give whoever is speaking all the time and energy, but also to manage the interruptions. Secondly, we're going to have our keynote speaker speak, and then the panelists, and then we can engage by putting up our hands, and then you'll be selected. But in between that, some of us may have hot questions, may have reflections, may want to share. You can use the chat to share, as well as the Q&A to share. We'll be able to extract those questions there. And then lastly, as much as possible, let's make it a space where we're all enjoying ourselves. We know of late we have a lot of cyber harassment. We have a lot of people hacking into webinars such as this because it's talking about an issue which is on the periphery of society, a highly controversial issue, which is SRHR. With that, I'd like to welcome Hope on board to come and give us a keynote address. And her keynote address is really breaking the ice. The keynote address is going to explore sustainability of the SRHR movement amidst COVID-19. We're going to explore how to make this movement sustainable in the face of the pandemic, but also how do we make SISMWA as a coalition and other like-minded coalitions that are working around bodily integrity and choice, that are working around the right to abortion, that are working around unsafe abortion being dynamic and responsive to the new normal, but also what lessons do we learn from a regional perspective? What can we learn from the others? And how can we as a coalition reposition ourselves in such uncertain times? Hope you are well. Welcome.
Thanks very much, Salome. I'm humbled to be part of this. I'm going to start my presentation by sharing my experience of cholera in Zimbabwe. So when cholera struck Zimbabwe, it was among the poor, what we call high density areas in the country. They died, they died, they died, they died. The Americans, the British heard about it, but they didn't care. It had nothing to do with them. Life went on as usual. And, you know, we recall that when Ebola struck West Africa, it was the same thing. People died and died and died. But then comes COVID-19, very powerful virus, and has removed all the masks, subjugated presidents and royalties, poor and rich, made us travel on the same journey, even if we are in different vehicles. The unprofessional part of me, the malicious part of me, says that, yeah, that's okay. At least they have seen what we went through. They have experienced what it means to live in fear, not to know who is going to be next, but that is then professional and gone with a good part of me. So here in Uganda, we have seen, you know, the measures that have been taken for, you know, to assuage the situation. I'm going to look at the impact of COVID on women and girls. Then I'll talk about some of the measures that have been taken and ought to be taken. I'll share some of the, you know, experiences from the region, you know, as Salome has said. The impact on women has been really, really horrible. When the president made an announcement of what he considered to be very, very urgent and emergent issues, I was shocked when he said that domestic violence was not one of those. It was around 9 p.m. I was, you know, in my house. Excuse me, I listened to him as he spoke, and I could not believe that he would say that, you know, domestic violence, ha, 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 is not one of them. And he went on and on as if, you know, it was a big joke. How could domestic violence not be one of them when it touches women from whose vaginas he came from? How could it not be an issue when we know that women are sustaining the economy, women are in the market, and they are selling food? Markets, they are selling food. He went on to announce that women should find accommodation in markets. Now, comrades, you know, even at the best of times, going to these markets takes a lot of energy. You have to think about it for days, strategize, think about the shoes you are going to wear, think about the clothes that are going to be suitable, think about your approach, think about how you are going to hide your money, think about so many things. And here was the president saying women should spend nights in the markets without shelter, without thinking about mosquitoes, without thinking about rapists, without thinking about sanitary towels, without thinking about all these things, as if he didn't come from a woman. What's her name again? I've forgotten, but anyway, he came from some woman. So I was very, very surprised. So in terms of the issues we are dealing with, that is, you know, for me, that really, you know, kind of summarizes everything. That is what it is. But, you know, as if that is not enough, then we came down to most of us staying in our homes. And what homes? For the majority of women, their way of escape is waking up, getting out of the home, even if you are not going anywhere. Getting out of the home because sometimes there is nothing to eat and you don't want to see your children, you know, hungry. Getting out of the home because it's not safe. Getting out of the home because you are going to find something small, even if you are going to sell an orange. But here they were supposed to stay in their homes with poor men, and there is a connection between patriarchy and poverty. There is a connection between patriarchy, poverty, and the devil. There is a way these three combine to really, really create violence. So women stayed in their homes, violence increased. We have heard of incest, we have heard of rape, we have heard of unwanted pregnancies. The activists have been at the forefront, you know, trying to do things. They eventually convinced the government set up a subcommittee to look at gender issues and gender concerns, or women's issues. It's really women's issues and concerns. I don't think there are many men who have gone out there as being pregnant and being raped and being battered. It's mostly been women. So they have set up this gender, but of course it's always a top-down agenda. But in this short time, shelters have been identified, and as of yesterday, at least from what I heard from another webinar, there are 1,200 women. And mind you, those are the ones that have recorded the stories of women. There must be many others that are not recorded. So imagine in such a short time, there is this, you know, kind of response. But the question is, where will these women go after, you know, like tomorrow? Where are they going to go? Because soon, you know, we are going to go back to business as usual. Today I was talking to a friend, one of those provocative friends, a friend, you know, who provokes you, and she was talking about how life has gone back to normal. The peace that we knew, I'm saying the peace, you know, as she said herself, middle class peace, where there wasn't so much traffic, where, you know, we were enjoying nature, where, you know, smoke was not the order of the day. But now we are going back to that normal. The beggars have found their usual place. They have reclaimed their spaces. The street children are fighting for their spaces. I used to be here, go away, this is my space. Before COVID, this is where I was sitting. The traffic is as ever as has been. Is this, Solomon, what you are calling the new normal? I really don't understand this term, you know, called the new normal. And it really just means that there is actually no new normal. So the situation of women, especially with regard to SRHR, is pathetic. I don't know what the doctors are seeing, but the activists are not happy. The women are not happy. They have cried out, not from position of victimhood, but they are crying out as citizens. They are crying out as women whose voices should be heard. they want to be recognized, and they want to be supported. And I think we need to understand that they are speaking out. They are critiquing the political power as exercised by government. They are venting their outrage at the failure of government to provide for them. They are saying they are citizens and they want to be heard. So this outcry is sending a message to many to look at the country and see where it hurts most, to examine where it hurts, to ask penetrating questions related to SRHR, and, to really, stand for the truth and to be told, to be bold and tell it as it is. So the coalition, this is one of your responsibility, to really look for where it has hurt the most during this period. And it's not over, it's going on. So in short, the approach has taken a salvation agenda. The task force is there, very impressive. Organizations have contributed money, very impressive. The coordination, I guess, is being done. There are so many things happening out there. But quite honestly, after all this, so what? Because even this salvation agenda has not reached everyone. Yesterday, I got a message from a friend who is not poor, and she said she had gotten, her portion and her beans. She said the beans don't cook very well, but who cares? If you have them, you have them. There are so many people who don't mind eating half-cooked beans if only they can have them. So for the coalition, let's ask ourselves, this salvation agenda has left a policy gap. But practically, in your own strategies, where are the gaps? How political is this agenda? How political is the subcommittee, is the committee, the task force on COVID-19? It's political in as far as they can push the party politics, because we have all seen that, pushing party politics, but it's not political in terms of tackling socioeconomic issues. So there is a gap, and there you go, SRHR, coalition. So as we move into the future, we need to think about some of these quick fixes and what they have done. Tomorrow, so the task force is going to say, thank you, it's over now, and we can all go and rest at home. What are they going to leave behind? And ask the task force, what are we going to do? How are we going to assert ourselves? Come in with a new agenda, our own agenda of fighting for long-term solutions to HR. So the degree to which the coalition will commit itself to achieving long-term HR reforms will determine its future and its relevance in part of its resilience, strategy. So here we are. Women have cried out. Governments have formed task forces at the last minute, as by the way, they have added the Gender Women Task Force, meaning that it has missed out on the past and it's supposed to catch up on what's happening. We were not consulted, no one was consulted, and you can say that is urgent, but there has been enough time for them to consult. And we have young women being, harassed. Incest has been reported, unwanted pregnancies are there, violence is there, women giving birth, and tearing at home, or even the babies dying or they themselves dying is there. Where do you stand as a coalition? What is your responsibility in such a situation? If you cannot rise up now, this moment, and really show, what you are made of. So talking about SRHR, and Some has, summarized what SRHR is. I want to go into this. We see that there have been decades of campaign on population and development that took place in Cairo, 1994. We know about the First World Conference in Beijing. We know about Millennium Development Goals. We know about SDGs and all that. We know everything, that has happened. And the right choice is not yet there. When we talk about right choice, people are quick to talk about, abortion. Abortion is part of it. But I think right choice is deciding what you want to do. Given all the information that you have, what do you want to do? Deciding what you want to do without information doesn't mean anything. But when we talk about political work, about politicizing the movement, we mean that we are going to give information and people are going to choose based on that information. So when it comes to these choices, we have religious groups that think they have a right to set the public agenda, set the public policy agenda, religious institutions who were not elected. And it's always assumed that they know better. And even people within the coalition talk, they always talk about, the coalition, they will talk about the Bible, what it says and what does it say, as if everyone thinks about the Bible before they eat, before they shower, before they have sex, before they make people pregnant. If people thought about the Bible before they take irresponsible behavior of making someone pregnant, raping or incest or even, whatever it is, then probably we wouldn't have these problems. But how is it that people talk about the Bible, Quran? Actually, Quran is not quoted very much, but mostly the Bible, and people saying, yeah, but the Bible says this and says that. How is that? That the Bible comes in when it comes to women, but when they are having sex, they don't think about it. So, of course, if you go and say that, you'll be in trouble. But I think that it's time to find ways of talking to culture and religious extremists who have attempted to influence public policy, and they can do this because they have the numbers. It's time for us to talk to them and find ways of using their own weaknesses and their strengths to enable them understand issues of SRHR. There have been many stories of, rape, abuse, and all that, but we don't denounce. We are patient. So maybe we should, find ways of approaching the situation, and and how we can support SRHR using their language, using their. Let me talk about abortion, right choice. Abortion, right choice. When we talk about abortion, right choice, we are not talking about forcing women to stand in a line and abort every pregnancy. We are talking about women having choices to do what they think their bodies need. Imagine the pain of a 15-year-old, pregnant, alone, scared, completely unprepared, unsupported, performing a backyard unsafe abortion. That is the experience of many young women. And this 15-year-old could be your daughter, could be your cousin, could be your little sister, could be anyone. Imagine that. And how did the pregnancy came about? Either someone told her that he doesn't make women pregnant, some father forced himself on her, a brother, a stranger, anything could have happened. She might even have agreed without knowing, the implications. This young woman, if she doesn't have a right to choose, her life is in trouble. So women will seek abortions when unwanted pregnancy presents excessive strain on their family, on their emotional or economic resources. During the lockdown, many of them didn't have much choice. And sometimes women will choose either die or survive. They don't care. They will go ahead, and do it. So imagine a situation like that, someone coming in and saying that, women shouldn't. Who is this someone who comes in someone's body and decides what should be done? Where do rosaries come in? Where do Bibles come in? Where do Qurans come in? They don't come in, in any way, because this woman is struggling to just do the right thing for herself, for her future, for whatever, she thinks she can do. So, comrades, this is the situation. But we have, we shouldn't give up, because some countries have succeeded in making abortion, legal. We have got Zambia, which permits abortion for health and socioeconomic reasons. We've got Cape Verde, we've got South Africa, we've got Mozambique, Tunisia. Some of these countries are no worse or no better than us. So it means that with persistence, we can do it. I could go on about contraception, but I think you know it. Many of you know what it means, to want to choose among the different methods of contraception, but you can't because you can't afford. So you go for the cheapest, which is not always the best. But that's how it is. So it's very important to have free birth control. In whatever form, but also in a form that suits your body. And the thing is, yes, it suits your body, but why should women have to shoulder the burden of the cost? Men and women have sex. In fact, men look for it usually much more than women. Why should women be the ones to pay for the birth control? Women already have to tackle the medication, the side effects, and whatever happens. If we got sexuality, the situation is very clear. Remember, Kill the Gay campaign? Kill the Gay campaign. You may not have been part of that campaign, but it was a campaign meant to kill your sister, your friend, your brother, your cousin, just because they experience sex, differently. But heterosexuals, do you all experience sex the same way? Why should you want to kill a person just because they experience sex differently from you? What has that got to do with you? They do it in their own privacy. They are adults. Mind your business and they'll mind their own. So we can't choose human rights to address and the ones to discard just because of our own beliefs. When we become a coalition, we have to agree on the values. We have to agree on what we consider excessive abuse of human rights. We have to agree on how we are going to go about it, on the strategy. If we don't do that, the coalition will die. So I want to briefly talk about strengthening resilience of the coalition. We have to strike when the iron is still hot. The iron is still hot now, and we have to manage expectations. People are there, some are in shelters, some are in their homes, they're everywhere. They have experienced what they have experienced. If we don't rise to the occasion, we may as well be declared redundant and given redundant pay and pack our bags and go home. So now is the political moment strike, because I understand that some of the religious leaders have been sending women to shelters. They have experienced what we've been talking about all along. The community's culture, leaders that have been anti-SRHR, they have witnessed what has meant, what it is. They are also sending women to shelters. So let's capitalize, on the moment and try and see how we can really, go crazy of healing. So with that, I have talked about COVID-19, how it has affected everyone. I've focused on the situation of women and what that has meant. I've talked about some of the issues that are emerging as a result of COVID-19. I've talked about the task force that has been created to address urgent gender issues. I don't know who has consulted, who has not consulted, but I hope that some of the feminists that I know over there have talked about this, and I'm saying this is the right political moment. We either act or we just pack our bags and go and grow potatoes. Potatoes won't complain. Now I want to talk about, resilience. And I want us to borrow from the HIV and AIDS campaign in Southern Africa. This campaign was not perfect. But in order for the campaign to get support around difficult issues and engage different stakeholders, the coalition, the HIV and AIDS coalition, developed a compelling frame. And I think some of you will remember that campaign that was developed on issues of treatment. You remember the days of Mbeki, you remember Kozana, you remember how they reacted to HIV. But there was a very, very strong movement that framed the issues in such a way that they won. So when we talk about a compelling frame, what do you mean? What do we mean? The statement begs the question of what counts as compelling and why it is important. Frames are rhetorical messages that describe what kind of problem is being faced and how they can be tackled. They can be about anything. So when I think about the coalition and I take an example of just abortion, are we really agreed on these contested issues? Even feminists are not agreed. Are we agreed on key issues in the SRHR? We can be agreed perhaps on family planning, we can be agreed on safe, motherhood, but are we agreed on some of the most contentious issues of HIV, of abortion, and you know that? Or do we sit in the coalition and say, hey, we are going to do this, but really nothing happens? So a very, very good example of framing is the way that HIV and AIDS sector dealt with this. So the decision in the late 90s and 20s, I think, about HIV and AIDS treatment as an issue of justice and fairness was a cautious choice by advocates. They said that it was simply unfair that developing world people living with AIDS had access to very same drugs that were not available to people in the developing countries. So they created a connection between the poor's lack of access to drugs, pricing policies, and then the difference between that and the rich countries. They brought in drug companies that were trying just to get profit no matter who died. It didn't matter. They wrote letters, they campaigned, they strategized, they appealed to the consciousness of different groups. Even religious leaders soon came on their side. They went to the labor movement, they went to the women's groups, they went to different groups, farmers groups, and they presented their case. The framing was such that it appealed to everyone. So what I'm saying is, when we take time to frame things, we have to do it in such a way that we look at our stakeholders and understand who is being reached and who is not being reached. We have to appeal to the youth, we have to appeal to the clerics, we have to appeal to the nuns, we have to appeal to the imams, and that's not easy. It takes time, but it's very, very important. So frames have an important political function. If they are deployed very well, they can make a difficult political opponent to have rhetorical resources to respond to the legitimate delegitimizing certain policy positions. They help fix some of the really, contested issues. So, Coalition, let me ask you, how powerful is your frame? How do you frame the issues you are working with in such a way that everyone understands them? I hear people talking about abortion, but we are not just talking about abortion. We are talking about freedom of choice. I hear people talking about homosexuality. It's not just homosexuality, it's freedom of choice. Even heterosexuality has got freedom of choice. We all don't have sex the same way. Are we agreed on what we are fighting for? Can we frame it in such a way that people understand? So as we know, the HIV and AIDS movement treatment action campaign took government court. They were able to present their case in a compelling manner. They were able to get support from trade unions, from religious institutions, from the women's movement, from the youth movement, from political parties, and they won. Woo, they won. If we went to court to present our case on SRHR, who would come with us? Have we done enough work to really think about framing the issues around HRS, around sexual and reproductive health and rights? Have we done our work in such a way that we can present it in a way that is compelling, that is, urgent, that is political, that people really understand it? People should understand the politics of their body. There is no one, whether it is an imam, whether it is a priest, whether it's a bishop, who wants to have their bodies owned by even their wives. There is no one. So if that is the case, how can we present the case in such a way that it's compelling, that it's interesting? Second, when we think about change, we have to think about what needs to change at the individual level, what needs to change at the informal, the norms and practices that inform who we are, what needs to change in terms of policy. And all these different, quadrants, different, spaces need different strategies. So if you want to change individual consciousness, what do you need to do? If you want to change the informal norms, that when people say, oh, it's our culture, what we need to change. If we say we want to change formal policies, what do we need to do? The strategies are different depending on where we are. I've talked about the importance of framing. I've talked about importance of understanding where to target and the different strategies that should be used. I have talked about the importance of reaching out to a wider community. So as I continue, and I'm about to finish, I want to talk about feminist leadership and SRHR. Women have been at this for a long time. Feminists have been talking about body integrity for a very long time. So SRHR is feminist work. And you don't have to be a woman to claim this feminism. You can claim it. Feminists may not allow you to come and stand in front of them and tell them what feminism is because they know what it is. You are not in their bodies, but you can claim it and support. So it makes sense to understand feminism. Feminism is not against men, it's against patriarchy. And anyone can be patriarchal, a woman can be patriarchal, a man can be patriarchal, anyone can be patriarchal. So feminism is against patriarchy. So learn about feminist leadership and put it into practice. You don't have to look at us as women's organization and say, hey, how come you do this and this? We are learning on the job. Come and join us and learn on the job. Learn about feminist leadership because one of our core values in feminism is analyzing power and control and culture and economic and political and legal structures. In the introduction, someone talked about power. Power is everything. When people say our culture, they can say that because they have the power to say it. Otherwise, how do you say this culture? Culture, who sat there determined which culture, which meeting, were we there? So power is everything, and we need to understand how power operates to empower and oppress. So, but feminism does more than provide analysis of women's oppression. It also assists us to understand power differences within oppressed groups. All oppressed groups are the same. Even when we talk about women that we have been doing, all women are not the same. Some women are privileged, some women are not, some women are happy, some women are not happy. We have to understand the importance of respecting differences, intersectionality. So feminist analysis helps us to understand, how power operates among different, groups in terms of culture, in terms of age, in terms of sexuality, in terms of ability. Let's try and take time as a coalition understanding what feminism is. We are not perfect, we are learning, but I think you won't find a better way of understanding SRHR without understanding feminism. There are many other strategies that I can think of. First of all, we have to ensure that we have knowledge, expertise, and strategic sense and courage to meet the real threats resulting from inappropriate religious institutions who try to play, a role in public policy. Imagine, a priest will go and talk to Museveni and say, I don't think this should be done. This priest was not elected by us. And he will listen because the priest has got a constituency. So we have to engage them. We have got to be at the forefront of national and regional debates, especially intersection of faith, culture, and women's health. So a culture person will go and say, these women, they usually say women, even if they are men, they want to dilute our culture. But this culture, what is it? And even East African culture. I live in Zimbabwe, and I think that there is a difference in culture between Zimbabwe and Uganda. Even in Uganda, we are not the same. We come from different parts. So we need to be able to be strong to understand this argument that doesn't hold water. When we say our culture, what are we talking about? There is nothing like African culture. We are all different, and we have got different histories of colonization, different histories of where we came from, different, histories of who we are. We have to ensure that all people have access to safe and affordable reproductive health services. And we also need to confront conservatism in our own groups, in our own coalitions. If people are conservative and they are working against you and they are going to shoot you in the end, then why are they in the coalition? Even if you are few people, it's better to be few, but agree on major, principles. A contested issue, of course, you have to create room for contestation, for agreement, and for moving forward. But you can't always be held back by people who don't understand. So in this section, I've talked about framing. How do we frame our issues of SRHR? How do we frame in such a way that we bring everyone on board? There is a lot to understand from the South African Treatment Action Campaign, TAC. South African Treatment Action Campaign, in terms of how they lobbied for accessing medicine for HIV and AIDS. We need to study that and see what we learn from that framing. We need to understand even the meaning of framing and what is comparing and what is not, because without that, we are going to continue going in different directions. Someone will say, women want abortion. I really don't agree. For me personally, I don't agree. But they are crazy and we get donors and they want the same thing. So I'm signing on. That won't work. Some will come and say that I'm totally opposed. But for the sake of peace, I'm going along. Someone is going to come and say, I don't agree with feminists. They are crazy, they are crazy, they are crazy. But they seem to be running the world. What can we do? They are there. We can't kill them all. Of course, you have tried to kill us, but we are still here. And someone will come and say something. Be agreed on what you want to do, frame it very well, put it outside there, and then get support from community. And that is another thing, get support from community, because without support from community, you can't go very far. And finally, I want to talk about some of the measuring, the shifts that you might want to make. How do you measure your work? Try and look at the shift in terms of women numbers, diversity, behavior, actions as change agents, activist leaders. Are the numbers increasing? The numbers of women, even men, even youth, even others, in terms of diversity, are they increasing, or are you stagnant? Look at the shift, that is number 2, in the quality and agility of political relationships and engagement. When you think about horizontal and vertical linkages that you have established as a network, what is happening out there? Look at shifts in terms of norms, ideas, public discourse, specifically stigma, taboo, denial about sex and sexuality, tolerance for violence against women. What is happening? Are there shifts in norms, ideas, public discourse, specifically stigma and taboo about sex and sexuality? The way we deny that we don't know anything about sex and sexuality, and we found ourselves in the world, we don't know how we got here. We just know we are here. We don't know what was done in order for us to get here. This sex and sexuality, we know nothing about it, and we're not going to talk about it. But sexuality openly. And then shift in engagement with decision-making structures. The decision-making structures, are we able to engage? Are we able, to have a voice? Are we respected? And these are some of the shifts that you can, think about. So as I conclude, I want to say that there have been pandemics. We can learn from the pandemic in Zimbabwe, the cholera. We can learn about Ebola in South Africa. But above all, I've given an example of South Africa, the HIV and AIDS campaign, the treatment action campaign, how they did it, how they sued government and pharmaceutical industries, and how they won. It's worth studying, especially in terms of the way we talk about our issues. I've talked about taking the political moment now. It's now or never, because if you keep quiet, you are going to remain redundant. If you keep quiet, shame on you if you do, but I'm sure you won't. You are going to remain redundant because this is the moment. Communities are waiting for you. Individuals are waiting for you. Institutions are waiting for you. Speak up. You have to pretend to be crazy if you are going to do this. And I don't think that if you remain a good girl, a good man, that you do this. And I've talked about some of the shifts that you might want to make. In other words, I've talked about measuring change. So this is what it is, friends. I could have gone on, but others, with more experience than me have got things to say. But the most important thing is that this work we are doing is political, and the way we do it is highly political. If you are not, go and grow potatoes. They are there waiting for you, and you can go and sell them in a sale market or wherever. So thanks very much for listening. Thanks very much for the space. And Salome, this is what I have to say. Thank you.
Thank you very much, Hope. You'll all have to agree with me. If none of you is listening in there and is uncomfortable with Hope's keynote address, then something is totally wrong. Because there are many areas that we felt uncomfortable, many areas that we felt really fallen short, but also very inspired and really looking forward to taking the coalition to its greater strength. More importantly, are we ready to be in the business, or we want to go and grow potatoes? Now, I'd like to leave that at that. I'll challenge you at that, but remind you, the Q&A is still empty. Please use it. But also we have a number of comments that are in the chat that have been passed on to the respective presenters. So with that, I'd like to invite Ezia. I'll swap a bit because Ezia has to leave at around midday for her to come and give us a presentation for 10 minutes on responding to the opportunities and challenges presented by COVID-19 and the future of SRHR advocacy. Of course, that now starts to tie in within where the keynote left us. And how do we as SISMUA ensure that the gains made in the coalition on unsafe abortion are not lost? Because they are gains, but we might lose them because already we are losing some gains. And then what opportunities and possibilities exist? Lastly, what does COVID-19 mean to advocacy and how do we remain relevant as SRHR advocates? And of course, that takes us back now to Asia.
Thanks so much, Salome. And for me, it's quite an inspiration to follow the presentation of Hope, wide-ranging and comprehensive as it is. So she's done all the heavy lifting for the panel, I think. So what I'll try to do is focus on what the coalition has been prioritizing and what it means to now be confronted with everything that COVID-19 exposes about inequity and oppression in society. And I think it's my hope that from this webinar, we leave not feeling paralyzed or overwhelmed, but instead recommitted to political action and to smart engagement as a team. Because that's our obligation as people working for comprehensive sexual and reproductive health and rights access. It's particularly a particular pleasure to follow after Hope's presentation because, to be honest, my organization, Health Gap, was founded in 1999 because of that pronounced, deadly, apartheid-like inequity that Hope referred to in South Africa and around the world. In fact, we were privileged to collaborate with the Treatment Action Campaign after its founding in 1998 to challenge the role of the US government in opposing South Africa's efforts to accelerate access to generic, affordable HIV treatment. And have since then, up to this day, collaborate extremely closely with the Treatment Action Campaign in national, regional, and international activism to fight for global AIDS treatment access and health justice overall. And it's actually that brought us in partnership to SISMUA and to collaboration with SRHR and other leaders in health justice work, because as Hope has rightly pointed out, the discrimination and inequities that people with HIV face are in many ways similar to the inequities that drive a wedge between women as well as people of all genders and access to comprehensive sexual reproductive health and rights services. This is fundamental healthcare. It's fundamental defense and promotion of human rights. And it's about the kinds of principles of autonomy and the vision of liberation that Hope so eloquently described at its core. And in Uganda, since the creation of SISMUA in 2011, we have in fact seen incredible setbacks, but also massive progress, which many of the people on this phone call and on this panel have driven forward. So here we are, we're more than 2 months into massive societal restrictions. And like all of you, I'm very concerned that our fragile gains are under massive threat. We see it everywhere around us, from profound spikes in violence in homes targeting women and children, to deaths of pregnant women trying to seek safe antenatal care, but dying on the roadside instead, to the deaths of women, we know of at least one, from an unsafe abortion, to the heroic work that SRHR and other lawyers have done to respond to legal threats of health workers who have been trying to provide post-abortion care, for example, and have been instead charged by the judiciary with violating the penal code. This was all in the context of pre-COVID, us looking forward to accelerating the work of the Uganda Law Society and the Legal Reform Commission, who were exploring revising the penal code, following hopefully in the footsteps of many other East and Southern African and West and Central African countries who have actually explored making the laws and policies of their countries more responsive to the health needs of women. Mozambique was mentioned, as well as Rwanda, as well as Ethiopia, Cape Verde, to name but a few. And now we're dealing with COVID, where we'll emerge after June 4th, and the epidemiology will speak volumes. There'll be a spike in maternal death. There'll be a spike in childhood suffering and death. Economic decline that we know hits women the hardest will be profound. We see incarceration of Ugandan women in particular who are trying to sell small fruits on the road, instead attacked by police. All of these things relate to the core struggle of sexual and reproductive health and rights. And that's the beauty of our advocacy work, is we don't just look at political issues in silos, we look at the entire system and what we must do in order to fight for the very concrete shifts in outcomes and access that women and their families and communities require. So what I'd love to see happen during this period, Hope pointed to the planning, the task forces, the sitting in Kampala. Frankly, like many of you, I think we've all been extremely frustrated that government chose to announce a lockdown, and yet they refused to put the work into planning in advance access to these essential services when everyone could see the monumental and catastrophic effect it would have on women's lives. As an activist, what that means to me is that the collateral damage wrought didn't rise to the level of concern to provoke the kind of planning and investment that was required. So that's an incredible wake-up call. We haven't made enough progress to show to decision makers that that kind of grave misstep is a political miscalculation. So that's a wake-up call to us. Now, we haven't been quiet. No one's been sleeping. We've been working hard, even at the task force level, to try to wake up duty bearers, but also on the streets, in our communities, in the judiciary, fighting back. And we've been able to challenge, at least to witness, to document, and to try to fight for small policy gains wherever possible. For example, we all worked together to challenge the president to announce a lifting of the ban, at least for pregnant women, on movement. Now, that's far from sufficient. Pregnant women never should have been included in the ban on movement in the first place. I would include anyone who needed essential health services, regardless of gender, in that category, but at least it's something. Likewise, there's been intensive human rights violation documentation work so that we can bear witness and demand that the next time lockdown comes around, essential health services are actually catered for, and those must include essential sexual and reproductive health care services. But let's remember what Hope also tells us. We have to work together as campaigners and bring together other people with political power to fight for these minimum investments and minimum commitments. So I guess the question for all of us to consider is, how are we going to do that right now and moving into the post-COVID era, which to me must anticipate the next wave of lockdowns and restrictions, because they'll come in cycles. we can look ahead 3-4 months and we'll be in a similar situation. So the question to all of us is, how will we use the next wave to secure a different outcome, so that the lives and the livelihoods and the access to essential services for women and their families and communities are different next time around. And we don't just see duty bearers lifting their hands and saying, well, in order to keep everyone safe from COVID-19, some people had to suffer and some people even had to die. Which, if you read news reports of some recent very unsafe births, maternal deaths, you actually saw Ugandan duty bearers saying that these were unavoidable collateral deaths. That is absolutely untrue. No system of COVID-19 planning has to put a woman in the line of fire. On the contrary, communities know better than many duty bearers how to deliver essential non-facility-based services in ways that uphold human rights and prevent the spread of infectious disease. Communities have been doing it for generations. So we must gather the evidence, gather our demands and our recommendations, our non-negotiables as a coalition, and campaign for them urgently, so that the next time around, we're not only not seeing the same violations, but we're actually seeing progress. Because as people know, the next few months, not only will see COVID potentially restricting us further, but the elections for the country are also right around the corner. So we have a very narrow window of time within which to advance a very ambitious campaign of demands. And the burden is on us to move forward as a team, and to secure these victories and to secure this progress, because the fates of countless women and their families and their communities literally are hanging in the balance. So thanks a lot for the work of everybody, all the communities and networks on this call. And I look forward to the debate and the discussion and the questions and the collaboration moving forward. Thanks.
Thank you very much, ACF, for building on from where we ended, but also for allowing us to be positive in terms of some of the achievements we registered in the past, as well as some of the key areas of engagement we've engaged in to open space, and also ensure that our mission as the coalition doesn't go to die, especially when women were not included amongst those that were supposed to be moving without needing the permits, but also challenging us to realize that it is still a steep slope. So I'd like to take us to Dr. Carol Sechimpi, who is a service provider and who is going to share the priorities and experiences in service provision. Remember, SRHR services were not among the essential services. However, the world has not come to an end because of COVID-19. People still needed the services. And so we're going to look at what the pertinent SRHR issues are, how they've been impacted on by the pandemic, but also the experiences as Mary Stopes. Dr. Carol, you're welcome.
Thank you, Salome, and fellow panelists. And as you have ably said, my comments will be biased towards service provision because Mary Stopes is primarily a service provision organization. And to start off, I want to acknowledge that the COVID-19 pandemic presents to us an unprecedented challenge. We have not seen something this big, something that is global in a while. We've had pockets of outbreaks in countries. We've had Ebola, we have had cholera, we have had several outbreaks, but we've not seen something like this. So it's helpful for us in the way we address these issues to understand that the challenge that is before us is unusual, and many of us are going to have to learn as we go in terms of how we respond to this challenge. And I want to acknowledge specifically our donors and the Ministry of Health, because they have shown very good flexibility and adaptation in responding to these challenges. As my fellow panelists have highlighted, we have our ongoing reproductive health issues, we have our policy gaps, we have our restrictions But my discussion today will focus on the response to COVID-19. And also, as it has been highlighted initially, SRHR was not classified as an essential service during the response. But I must acknowledge that when we did the advocacy with and have nailed just two things. The first thing is that COVID-19 comes with a restriction to access of SRHR products and services. What this means is that providers cannot access clients and clients cannot access providers. And this one is nested in the travel restrictions. As you know, we had suspension of both public and private transport. We had suspension of public gatherings of people more than 10 or 13. When you think about the way most of our services are delivered, especially in the rural areas with the outreach settings, go around and mobilize clients and bring them together for service delivery. So this is impossible in the time of COVID-19. The other one is the issue of social distancing. When you think about your typical health facility, crowds in the waiting areas, crowds in the compounds, crowds in the maternity wards, crowds in the gynecological rooms, becomes difficult. So because of social distancing, we find ourselves having to see fewer clients and also therefore not meeting the need that's out there. And the last one is the requirement for protective equipment, personal protective equipment. From a programming perspective, that just means higher costs of service delivery. You must find a mask, you must find extra face shields and all of these things to cover service providers. But now, even the women and girls and the public at large are required to use personal protective equipment. Everyone's supposed to have a mask before they move into a public space. And so far, we haven't seen the masks being distributed yet. So that means that a section of our clients, a section of women and girls who need services will be unable to access them simply because they don't have a mask. So we see a lot of restriction of access to services. The movements, when you think about, for example, an outreach team going to take services to a community, we have curfew. That means working hours have to be shorter. Even in private hospitals and clinics, generally the evening shifts have been scrapped because of the curfew. So access has really been affected during this COVID response. The other thing beyond access of services is access of commodities, and this is cross-border. It doesn't affect, it's not a result of what's happening in Uganda alone, it's what's happening in Mombasa, it's what's happening in India. This means that we have to have longer lead times for imports of sexual reproductive health commodities. Condoms, pills, all of those, most of them are not manufactured in Uganda. We have to import them from elsewhere. And because of the lockdown, we have delays. You have seen what's been happening at our Malaba border. We have more than 60 kilometers of trucks waiting. Who knows what is in those trucks? It could be condoms. It could be emergency contraceptives. They're sensitive to temperatures. So you're going to compromise quality and the whole work. So we've had a disruption of the supply chain for SRHR commodities as a result of the COVID-19 lockdowns. And this in Uganda coincided with the ongoing change, which is the ADS transition, which we're moving to one facility, one warehouse. This is an excellent initiative to improve accountability for reproductive health commodities, but it requires a lot of coordination. It requires a lot of planning and engagement, especially down at the health facilities, especially public health facilities where they're expected to order for reproductive health commodities. Some of them have not ordered for these commodities before. Some of them have depended on partners initially to do these forecasts for them and to provide services. So when travel is cut off, this whole conversation is cut off. And indeed, we have experienced stockouts of reproductive health commodities, especially implants, at the level of health facilities. So that is restricted access. The other thing that the COVID-19 pandemic has done to us in terms of service delivery is increasing the vulnerability of women and girls. There's no doubt that domestic violence is on the increase. I saw the Minister of Labour and Social Development announcing that they have registered more than 3,000 cases above the usual of domestic violence. And quite often we know that this domestic violence takes the form of sexual violence. Besides the fact that women and girls and men are locked at home and they are quite redundant, they are also losing livelihoods, and people tend to be angry when they are broke. So, you know, loss of livelihoods, increased dependence because women who would otherwise go and fend for themselves are unable to do that, the redundancy at home, and just the general stress of being unable to live a normal life seems to create the right breeding ground for domestic impact of this increased vulnerability. We're going to begin to see the impact 3 to 9 to 12 months down the road. But many of them are going to take the form of complications of unsafe abortion, complications of unplanned pregnancy, and complications of young girls and teenagers being beaten, you know, emotional abuse. You know, many times we tend to focus on physical things, but emotional challenges tend to have far-reaching effects, and they tend to last through people's lifetime. So it's a little bit early days to be able to measure that, but we expect that we're going to see the effects of the increased vulnerability over time. In terms of our experience as service providers, I have to say actually that overall, I think we've had a positive experience. Whereas it is true that SRHR services were not gazetted as essential services at the beginning of this crisis. As I said, we did engagements with both the districts and the Ministry of Health, and the response was quick, and services were able to continue. So I like to think of that as a positive experience overall, but also I'm reminded of our work as advocates to keep talking, because likely we're going to be forgotten. So we have to remain on our toes and banging in the message, making sure that SRHR is not forgotten. In terms of our impact, for us as Maristopes, our biggest channel of service delivery is the outreach. And in the month of April, we registered an 80% decline in service delivery for the reasons that I've highlighted above, that we couldn't move and the clients couldn't move primarily. But the effect is variable in different sectors. In the private sector, it was softer. That is in the clinics and our social franchise, we saw a decline of about 30%. And that's not as bad as the 80%. And in the public sector, surprisingly, these were the worst hit, mainly because they were the only alternative that's available, and perhaps the ones which are most rural and most near to clients. So there we saw a dip of only about 15%. What I want to highlight to listeners today, though, is that we see a positive trend towards a resumption of services. We see a lot of district engagement. We see Ministry of Health. We see a lot of adverts reminding people about contraception, reminding people to remain empowered, reminding people not to, to take the COVID break as a vacation, but to keep thinking of their futures and their plans, and therefore take control of their fertility, which I think is really, really positive. So we observe that is happening. On the front of the supply chain, as I said, we have experienced shortages of implants. We have experienced shortages of commodities that we import as Maristopes, the emergency contraceptive, condom delays, and this, as I said, is the result of the delays across the different borders. So all in all, from the perspective of Maristopes as a service provider, COVID-19 has presented an unprecedented challenge. The beginning was difficult. The support has been overwhelming. We're making good progress and are optimistic that we will be able to sustain service delivery to Ugandans And hopefully as the lockdown eases, that scale will continue to improve. The ongoing challenges that we face, including the absence of appropriate policies, the SRHR policy, the policy for prevention of maternal mortality due to unsafe abortion, those are ongoing, and we don't want to miss the mark on continuing to plead with those in power to ensure that these ongoing challenges are addressed. Thank you very much.
Thank you very much, Professor Carol, for really walking us through the realities on ground and what it means with the directive, with the instructions, with the policy, but also with some of these declarations that are made, the reality of a healthcare provider, but also the implications in terms of the right to health, in terms of access, in terms of also the clients, as well as the health and safety and personhood of the health service providers. I'll take us straight to Dr. Chigundu, who is going to tell us on the forefront. You know, they say when you're in the forefront, for those of you who've gone to Kawempe Regional Referral Hospital, that road, the section near the hospital has traffic, which traffic is not cars, but traffic of women and girls wanting to seek maternal, antenatal, post-abortion care services. So Dr. Chigundu is going to share experiences of him as a practitioner, having to find his way around to get to Kawempe, to meet the multitudes of clients there, but also providing this SRHR services during this pandemic. Dr. Chigundu, you are welcome.
Yes, I am a service provider, and I do my service delivery generally in section productive health, and including rights. And yes, we have seen COVID. COVID has been with us, I think now for probably 6 months. But the lockdown, as a consequence of this COVID scare, has really affected section productive health service providers. I'll talk on the aspect of the service provider, but of course, I noticed that a lot has been discussed about section productive health outside the environment of the service delivery point. I want to start by probably saying we have had a challenge, and the challenge that we have had is probably appreciating that section productive health and rights is actually a right. Because as we saw, some of the things that happened in service delivery is that in most of the environments, section productive health rights and services were affected by the lockdown. Where I work, for instance, we had issues to do with, first of all, social distancing. You know, we're supposed to keep at least 2 meters from each other. And our health facility where I work, we usually have about 300 women coming every day to receive services in an environment that is basically small, prepared for a smaller number. We cannot actually access the safe distancing that is required by the presidential directive. Now, what did this mean? This meant that we either had to stop completely providing a service, and actually, we in some of the areas we were forced to stop providing a service. For instance, antenatal care. Yet we know antenatal care is an important aspect in the section productive health, and actually it sometimes provides the biggest amount of turnover in the facility. But we had a dilemma. How would we protect the women that come to us in a small environment that we protected from the risks of acquiring infection from this national pandemic? I think that was one of the biggest that we saw. The second one that we saw was even for emergency, even for women that required emergency services, we had a dilemma because we had shut down public transport, which is basically what they were using to get services. And we painfully heard of stories, even watched some of the pictures depicting our clients delivering on the way, and actually some of them dying from the processes of pregnancy and childbirth. We have also read of stories, and we have seen newspapers and women that have died from complications related to unsafe abortion, which is really a step back. It's taking us back in the gains that we had achieved as in sexual and reproductive health and rights. The other idea that we were able to see, what was a big challenge to us, was getting the health worker to the work site. And then this issue of changeover and getting shifts, because where you work, maybe there was a curfew that meant you had to leave before or arrive at your point of entry or point from where you come from, and at the same time you had somebody leaving their homes to come and receive a ward or to have what we call a takeover. So we found that in the circumstances of service provision, actually we had empty hours. Sometimes we had empty hours of no coverage or low coverage because of the requirement that people cannot travel in the night. And then the other one as a challenge was the issue related to safety. And we have been reading and seeing films here depicting how health workers in frontline states actually are getting trouble from acquiring coronaviruses from the clients that they actually see. This scare was real, and most of us were scared. And in the midst that we didn't have the protective gear that we were seeing those people put on, it became a challenge. And so people were really working, but the motivation was very low. And so the quality of care that was especially required in this sexual reproductive health service delivery, I think was put on a challenge. What to use? You see these masks that people are buying in some of the facilities where we work, the masks are not there. Because the health workers, some of them have bought masks, but you see, those protectives are supposed to be disposable. And then they give you a mask that is being prepared to be a medical mask, and they're asking you to use it for a week or to use it for 2 weeks. It really means that there's a feeling that we're actually doing more injury than good. So the access of services, especially what we call cold services like counseling, family planning, post-abortion care, emergency, medical abortion, those ones have been affected because of the facts that I've outlined above. One, the people, the women, the clients find it difficult to actually reach the facilities. Those who can walk, you can start someone walking from Gayaza, coming to Kawempe for a service. And they must leave before probably 4 o'clock because they must reach their home in Gayaza before curfew time. These are very demotivating environments for services that we generally deliver in our family planning clinical areas. Also, the health workers, yes, I've told you, sometimes they have to miss duty because they can. If you work, some of them you walk from Kasangati because you work in Mulago or in Kawempe. So you walk to work and then you are going to have to walk back. That is very disinteresting for the women that are providing, most of the women that are providing care in these environments. Now, for the ones that were able to get stickers, I think we had a little bit of relief when transport was provided through the task force via the stickers. Yes, but I think the essence there was that no one, who fuels the vehicle, who services the vehicle. I think those ones were never done, and some of those were disincentives for the providers, because as you probably would know, other people in this COVID campaign were actually facilitated, including parliamentarians with those, some of those things to use, but the frontline health worker who has money to pull out their small vehicle and they have gotten a sticker and then they cannot access fuel. They must put their hands in their pockets to actually get some of these things. And these are the motivators. And in fact, in some of the areas, these were affecting the presence of the health workers. And then we also had the issues with the referral. I think one of the biggest things that we're really having a problem to tackle was referring clients or receiving referrals. You know, sometimes people are referred from lower health facilities to higher health facilities, and they cannot travel with an accompanying medical person because the referral back sometimes becomes very difficult, and these people are not given transportation, including public free on public transport. Then also referral out. If you need to refer a client from Kawempe to maybe the ICU in the New York Women's Hospital, it becomes a problem because, again, the facilitation and the facilitating factors were not there. So you find you get stuck with a client, you know what to do. You have a woman maybe with this renal injury following CN section, you want to transfer her to ICU, and you just look on and lament with the attendants. The private, I mean, these medical bodies, what can they do? I know we have the Association of Obstetricians and Gynecologists of Uganda. We have Uganda Medical Association. We have Protestant Medical Bureau. All those ones. I think they have an advantage in healthcare delivery because they interface with the services. They interface with care seekers, so they speak from the point of knowledge. I think what we need to do with them is to recognize, to make them increasingly recognize and support sexual reproductive health services, because these are central. They form about 70% of health service delivery lingers around sexual reproductive health. And I think this should come in. Yes, I know COVID is there, and it's good enough. Well, maybe we have been lucky; we have not lost any COVID-related case in Uganda. But I know that we have lost probably close to 1,000 women, 1,000 people from other preventable causes in this country, in this area. And I think let us understand, or let the communities, let the public understand that deaths are deaths. Death from COVID is a death, but also death from an abortion is a death. A death from a postpartum hemorrhage is a death. And I think that we should not put priorities only on COVID-19. So we need to speak out on the roles of the providers, because I think it is increasingly becoming important now. If you must walk 2 kilometers to reach a facility, it is important that you find a health service provider who's motivated and happy to receive you and provide you with a good service. And I think we need to develop standard operating procedures, element of sexual and reproductive health and COVID, such that all aspects are covered. What do you do if a woman comes and requires a family planning method? If it is such that it cuts across and it is actually known. We need to protection. We need to protect the environment where service delivery is being provided. And there are different types of environments, and may require different types of protections that are known. Social distancing is known. We know, and how can we utilize this in antenatal care? How can we utilize this in family planning? How can we utilize PPE, protective attire, for patient and staff, clients and staff? Because these are important areas, things that are generally lacking in the environments where service provision is being conducted, and where maximum protection actually should take place. I think the medical bodies that we have, if they made a lot of noise around this might be, and to me, I don't think COVID is going to go away tomorrow. I know COVID is going to stay around for some time. Until either we have a breakthrough in vaccination or something. So we are going to have to deal with this. In its own way, this would be a wake up to health facilities, especially that in the public area, that I think we have been going down the protection area. If people are being asked to wash hands, it means we have not been washing hands. If people are being asked to keep distances, it means they have not been keeping safe distances. So this would be a wake up, and maybe we should be able to see an improvement in clinical outcomes. I was thinking about model clinics or model clinical environments where people can be taken or can be ready to see what actually should happen, so that we can actually copy information, and we need to inform the public. And I think the medical bodies here have an advantage. They can, because they are experts. They need to be able to inform the public, and if you hear it from the public, I mean from the knowledgeable provider, maybe that will think more. But we need to also look at staff. We need to to retrain staff in safer ways of doing this. We have been talking about these elements, but I think this is a bit of more on staff training and informing. And then policymakers. I think health workers, service delivery points should be able to engage, develop skills and engage. Health workers should engage policymakers, to engage managers positively, to be able to advance a protective and suitable environment for provision of safe services to everybody. I think the other thing is now everybody who needs them. And that's where we are really having issues. And I had the Maristops sharing some of their challenges. Because most of the people that we see in the facilities, the ones that we see in the facilities are very few. Most of them actually are in there, in Mombasa. And we need to see about how to reach them in Mombasa so that they can get a service that is quality. So as I end, I think we need to appreciate that COVID has been it has been a call that we are not prepared, probably. It also shows and gives us a sort of an opportunity of saying, what can we do in what is the other way of doing things? Because I think we have been stuck to all the clinical ways of doing things, but COVID gives us a chance to think outside the boxes, but also to be able to understand that COVID or no COVID, sexual and reproductive health services must be accessible. I know we are going to get baby booms after the end of the lockdowns. We shall be working our neighborhoods and getting many deliveries, but at the same time also going to have a lot of unsafe abortions as a consequence of people who have been asked to stay home, and they remain home and they are sexually active. So we're going to have issues there. Now, if the family planning services are not available, that means a double thing. And now also antenatal care services. That means that the women may not be nicely prepared to get out of this. So this should be able to say, what should we do as service providers? What should we do as CSOs? What should we do as SESMOA? Because I know, yes, SESMOA, we have done nice things, but also we have faced challenges. And we start to say, how do we think again? How do we rethink? What do we tell the government? How do we prepare our service providers and managers, especially managers, on how to support sexual and reproductive health and rights in our working environment in this era of COVID-19? Thank you very much.
Thank you very much, Dr. Kigundu, and thank you very much for being the voice of the frontline healthcare providers that had to deal with all the ambiguities, but also telling us what we really foresee in the future. beyond just managing this immediate crisis, but what will happen after a year? What kind of services will the women find there? But also what kind of challenges that we're going to have to deal with and contend with, and where we need to be as a coalition. Lastly, I'll now move the conversation to a regional platform where IPAS Africa Alliance Regional Director, Ernest, is going to share with us the provision during and post COVID-19, because after the crisis, what happens after that? What are the experiences? But also, how has COVID-19 affected abortion care service provision? Because like, social distancing, staying at home, but also rising rates of GBV, and the violators were required to stay with the violators within a closed familial unit. And then what needs to be done to ensure that we provide SRHR services post the lockdown. Dr. Ernest, you're welcome, and thank you for making the time.
Thank you much, Salome, and thank you the rest of the other speakers and panelists. IPAS is pleased to be a member of SISMUA, and I'm glad to have been invited to present to you on some of the regional perspectives. IPAS Africa Alliance for Women's Reproductive Health and Rights is a non-profit organization that is committed towards ensuring zero deaths from unsafe abortion by helping women exercise their basic human right to make reproductive health choices. We work to ensure that the legal and policy and health environment is supportive of this right to choose. As many of us know, today marks the International Day of Action for Women's Health, and more than ever, we need to commit ourselves to this action. The other speakers have noted that COVID-19 has changed everything. Our health systems were very weak from before, and what COVID-19 has actually done is exposed this weakness. Governments have rightly taken the decision to implement measures to prevent spread of the pandemic by instituting measures to limit social movement, social interaction, to increase personal sanitation, and also reorientating the entire health system towards COVID-19. What this has done is moved emphasis away from other essential services and exposed and created severe negative effects. In Kenya, what has happened is we've had a curfew dawn to dusk in the entire country, and in 3 counties, that is Kilifi, Mombasa, that is at the coast that people have spoken about, and in Nairobi, we've had a lockdown limiting movement in and out of those counties. And the effects, as you've seen, of limiting the movement is that countries as far as Uganda, which receives a lot of its supply from Kenya, are being affected. We've seen, unfortunately, the side effects of this lockdown through the effects of increased stigma. COVID-related stigma is a challenge. People are avoiding health services, and this has had a severe impact. Dr. Chigundu and Dr. Carol of Maristops have actually noted reductions in people going to health facilities. It's not that people are not falling sick, it's that they're just simply not going to hospitals. I have a personal story of my cousin whose daughter died just 2 weeks ago simply because she was sick. They thought no one is going to hospital right now. They gave her paracetamol and she died at home 8 months. These are the effects that we are seeing of people avoiding health services. The World Health Organization, in a fact sheet titled Disaster Risk Management for Health, Sexual and Reproductive Health, identifies that in times of crisis, disruptions in reproductive health lead to a range of adverse outcomes, the biggest ones being increase in sexually transmitted infections, increases in HIV transmission, and as mentioned earlier, increase in unintended pregnancy, unsafe abortions go up, as well as maternal and neonatal deaths. What happens is, as we limit access to health facilities, the quacks and the people who provide backstreet abortions are very active. They don't close down and they don't observe social distancing. They are continuing with their services. Now in Kenya, the government launched guidelines in April called the Kenya COVID-19 Reproductive and Maternal Health Guidelines that stipulate for the provision of services during the COVID-19 pandemic. These guidelines call for continued provision of services during the pandemic, including post-abortion services, for family planning, with preference for more of the self-care use commodities, including condoms and oral contraceptions. And health facilities are being asked to provide 3 months of commodities and refills to reduce exposure of clients to the virus. Institutions are also being advised to offer family planning on a 24-hour basis based on telephone appointments. However, as advocates, as providers, we all understand policy is one thing and implementation is another. Our health systems were never designed to provide this kind of services, and that is the challenge. What we are hearing from 10 of the 47 counties that we work in Kenya is that just like in Uganda, women and girls are avoiding going to health facilities. As it were, already the health-seeking behavior of especially young women was pretty poor. They tend to avoid health services because they are not youth-friendly, they're not youth-focused. It's even much worse now because you can imagine the look you will get as a young woman, as a young girl, if you go to a health facility and ask, can I have a condom, can I have contraception? And health workers or even the guards at the security firm might, at the gates might ask you, are you thinking about sex? And right now there's COVID pandemic. But I want to echo what Dr. Chigundu said. Healthcare is healthcare and a death is a death. A death that occurs from COVID and a death that occurs from an unsafe abortion is a death. People are avoiding going to health facilities because they fear contracting the virus and they're being stigmatized. So we have a double stigma. We have the COVID stigma and we have the stigma associated just generally with reproductive health services. Stockouts have been mentioned before. This is due to the lockdown. This is due to delays in delivery of commodities. The lockdown in India as well. So we're not getting supplies. So there's lack of supplies in the region. Kenya tends to supply the region. And even within the country, we are seeing lack of commodities and this increases barriers to access. So on one hand, we have the policies that are very clear that says, yes, services are essential, reproductive health services are essential. But the reality is the same healthcare worker that works in the safe abortion clinics that we support, 5 of the safe abortion clinics that IPAS supports have been converted into COVID treatment centers, which means women can no longer be able to go to these facilities to access services. The health workers have been told, focus on COVID. What is happening is women no longer have the ability to exercise choice. They can't control their fertility, and planned pregnancies are going up. It's been mentioned there's been an increase in gender-based violence. We have seen the reports. Sex crimes and intimate partner violence have gone up. Another key area is the economic stress is leading to increased intersectional sex and exploitation. Again, this will have the effect of increased infections, social stigma, unsafe abortion. And one issue that is actually not being mentioned and given focus, but actually I think might end up being the biggest effect of this pandemic is the mental health effects of this pandemic, of people being forced to stay at home. The first speaker, Hope, spoke about domestic violence and the effects of this from a mental health perspective, but also for young people. Staying at home and them being in an enclosed setting is not natural. That's why a lot of them act it out in terms of their engaging in risky sexual behavior. Now I want to focus on an opportunity. Winston Churchill, the former British Prime Minister, said, you should never let a good crisis go to waste. We have opportunities within this COVID pandemic to approach innovative ways of reaching young girls and young women and young boys also through telemedicine. This is an important aspect. So we should be able to provide self-care options for contraception, for safe abortion, and for other services through telemedicine, both high technology and low technology. That means online social media platforms, WhatsApp, working with trusted providers in the public sector and the private sector, pharmacists, apps that are there. Just the other day, I listened to a presentation from Uganda, an app that has been developed to allow young girls to interact and get deliveries of health products at home. So this is our chance to take advantage of the opportunities that we have to develop services for young people using innovative platforms. Young people are on social media, they're interacting, they use technology quite a lot, and how can we support them through these platforms? Now, as non-governmental organizations, we have an opportunity to use this crisis to advocate for the strengthening of our health systems. I want to mention, I'm happy Dr. Chigundu spoke about our healthcare providers. We need to support them. They're under extreme pressure. They don't have personal protective equipment. They're under a lot of pressure. They may get infected. They're expected to provide services. These are the same workers we're expecting to provide SRHR services, but also COVID services. How are we supporting them? As NGOs, as organizations, as partners, and as individuals, we should reach out to healthcare workers, appreciate them, support them mentally, but also directly, if we can, in terms of providing them with personal protective equipment. We must hold governments to account. Governments should ensure that we have access to SRHR, emergency contraception, NGOs should continue supplementing services being offered by government and doing fundraising to ensure SRHR remains on the agenda. We need to remove all legal and administrative barriers that reduce access to SRHR. We need to look at innovative methods like telemedicine. And I want to mention one last thing here, that we need to ensure the voices of young women and girls are heard. How do we do this? We need to document what is going on. We need not just to speak to each other, we need to put the stories out there. Let women speak and young girls speak and young boys speak what is going on. We need to publish their stories. We need to share widely. We need to publish. IPAS is working with other partners to collect survey information indicating the impact of the COVID pandemic on SRHR services, including maternal deaths that are recorded. And governments should also provide money. So just to end, I want to tie it all together by, I hope reminded me, when the Treatment Action Campaign started its work in South Africa, advocating for HIV, I was working as a HIV doctor in the South African clinic in Cape Town. So and I agree with her. At the time, the advocacy that was done doesn't have to be perfect. All that you need is a clear, compelling voice, a community voice, involvement of the people who are affected, that is young women and girls. Speak to our governments, we hold them to account, we elect them, we hold them, they are the duty bearers and we must hold them to account. We must do everything that we can do to support women. Women's health still matters. Thank you very much.
Thank you very much, Dr. Ernest, for bringing the regional perspective, but more importantly, for connecting issues that we didn't think were connected. As Ugandans, and especially members of this coalition, will understand and realize how in the last 3 weeks, we've spent so much energy and time fighting those trackers. There's been a lot of xenophobia against Kenyan and Tanzanian trackers, but the question you'd be asking, what are those trucks carrying? Uganda is a landlocked country. And also, Dr. Ernest has brought the reality on ground. Most of the medical supplies are either produced in India or China. Many airports are now closed. It's very expensive. It increases the cost of medical supplies. But more importantly, you are landlocked, and most of these have to come via road. So what do we speak? Are we speaking one voice and speaking another or not? But also how we can be able to overcome this, how we can leverage on this particular point in our story, our history, our story, their story, to really make change. More importantly, what we need to do with ourselves moving forward. So the time has now come. They've really, really challenged us. There's been many aspects. At the end of it all, it's all gotten back movement in the face of COVID-19. So I'd like to give us a few instructions of how we are going to manage the plenary. If you have a question, already I see there are 5 questions in the Q&A. There are a number of questions that are in the chat, which the panelists have noted. But also, if you need to have your voices heard, please put your hand up, and then you'll be selected to share your question. I'd seen 2 hands up earlier, but I now see that they are down. I don't know whether you still have your questions. I'd seen a hand from Moses Kunta and somebody else, but please put up your hands and then you can be selected, and your microphone is going to be unmuted by the host so that we can hear your voice, and then you share. As much as possible, we would like all to share if we can. So please make your points very clear, and if possible, indicate who you'd like to respond to your particular question or comments. And if there are comments and nobody's responding to, you'll indicate that it's a comment. So we begin with Mohamed Kunta and go to Chichoncho Grace and Roswa Chikona in that order. Mohamed Kunta. Mohamed, can you hear us? We can't hear you.
Hello.
Yes, we can hear you. Please proceed.
Okay, so my name is Mohamed Kunta. I am from Sierra Leone. I have listened to several speakers, including Dr. Ernest. In Sierra Leone, we still have a lot of challenges in accessing reproductive services. especially contraceptive like pills and condom because of the state of emergency. Some districts in my country that still cannot access reproductive facilities. We've written to Maristow Family Planning on several times, and people has made several calls in these areas that they cannot access reproductive facilities. There is already state of emergency here. There is lockdown, so people are not allowed to move from one district to another. Few government officials are allowed to move, especially those with pass, and those without pass are not allowed to move. And most NGOs are denying pass to move, especially NGOs which has been providing reproductive services like pills, condom, and contraceptive. So there has been huge challenges. And I want to learn from other African sharing out contraceptive or pill, especially countries that has lockdown or there is already state of emergency restrictions of movement. Because this is the biggest challenge we're faced in Sierra Leone. There is restriction of movement and goods and services are not allowed to move from one district to another. So how has other countries able to manage to move around with their goods and services, especially with regards to contraceptive facilities?
Thank you very much, Mohammed, and greetings to everybody in Sierra Leone. Grace Chichoncho.
Yeah.
Grace Chichoncho.
Hello.
Yes, we can hear you. Hello.
Hey. Hello.
Hello, Grace, we can hear you. Please proceed.
Oh, God. I can't hear you. Hello?
Hello, we can hear you loud and clear. Please proceed.
Yeah, hello. Hello? Hello, my name is Chancha Grace, Barbara Triagenda. Hello?
Yes, we can hear you. Please proceed.
I can't. My phone is warning. I cannot hear you now. Hello?
Grace, we can hear you. Please proceed.
Hello?
We can hear you. Okay, now let's go to Rose Wachikona as we sort out Grace's connection. Rose?
Yes, good afternoon, everyone. Good afternoon, everyone.
People's microphones are muted. Good afternoon, Rose.
Yes, my question was in regard to telemedicine. This is something that has come up time and time again, not just in this webinar, but in the others that have been attending. I just wanted to ask how feasible is this, given that we don't have any guidelines from the Ministry of Health or any law to support this particular function? And is this something that as SISMUA we can push in terms of getting some guidance out on how it will work in establishing a patient-client relationship, and how exactly would this look like? Thank you.
Thank you very much, Rose. We'll now have Tony. Tony Muzira. Tony, are you there? Tony, are you there? Let's move to Comfort. Comfort Abire. Comfort.
Hello.
Yes, Comfort,
Yes,
we can hear you.
Comfort Abire from Ghana.
Please proceed. You're welcome on the call.
Thank you. I would like to comment to Chichoncho Grace. She asked a question about how fast and quick and easy you think sexual reproductive health rights advocates can fully advocate for women and girls' freedom of choice to happen without freedom, troubles. And I would like to share my experience as being an IPAS youth advocate and a midwife. Yes, it depends on various factors, but the two I would like to touch on is the capacity building level of the advocates involved, and then the supporting systems available. When I say the capacity building level, this also has a lot of factors. You need to train the advocates to identify safe spaces in which they can see themselves in, and then talk to the youth, and then the communication skills, how to use social media platforms. And then when we come to the supporting systems available, we need to reach out to these people. Where do you get the funds for the outreach from? Where do you get the materials that you are going to use for your behavior change communication education? And all these things had an effect on how fast advocates can take place. Thank you.
Thank you very much, Comfort. Tony? Okay, let's go to Olga Duffin. Olga Duffin.
Hello, thank you very much, Salome. And thank you very much to our presenters. It was quite an interesting discussion. My 1 cent on the conversation is around our inclusivity as we are building, a resilient movement. How inclusive are we in our discussions? We were talking with a couple of colleagues just a couple of days ago, and the discussion was, well, we are setting up all of these webinars, and we are setting up the Zoom calls, and we're talking about telehealth, and we're talking about, e-health and other ways in which we can, innovate to be resilient and be able to respond to the COVID. But how about our colleagues who are unable to see, our colleagues who are unable to hear, our colleagues who are unable to read and write the kind of discussions that we are having, our colleagues who are, unable to connect, to have the equipment, to the computers and the phones and the internet bundles to connect to the conversations? How exactly are we thinking about these groups, especially, adolescent girls and young women, because many of them are out there, they are part of us, they are part of our movement, they are part of our discussions. But as we are building our resilient movement, as we are responding to COVID, all of our interventions seem to be targeting the young girl or the woman who is in a way kind of able to meet those needs. But how about those young girls out there who are now exposed to violence, who are now exposed to unsafe abortions, but they do not have access to these platforms? How exactly are we supporting them? And this question, I would like to pose it to all of the panelists and also other members on the conversation. Thank you very much, Salome.
Thank you very much for challenging us on that. We'll have now Precious Motoru.
Thank you so much, Salome, and thank you so much for the submissions to our panelists. My question goes to Ernest. You mentioned you touched a bit of self-care, and I'm curious about what mechanisms you've adopted in Kenya and where you're operating to popularize the self-care methods that you've made available for prevention and management of unsafe abortions. How you're able to share information and ensure that the young girls and women have access to this information. They know the methods that they're using, that they can use in this lockdown. Also considering that there's been restriction around movement. So I'm just curious I'd just like to learn from you how you've been able to do that. Thank you so much.
Thank you, Precious. We'll now have Susan Achen. Susan Achen.
Good afternoon, Salome. Thank you, and thanks to all the panelists. I just wanted to speak about access to healthcare services in these unprecedented times, and all the panelists have ably spoken about it. However, I think also as health professionals, healthcare service providers, there needs to be we need to be able to bring the services nearer to the people, physical proximity, because as has been mentioned several times over, this has not been able for many people to happen. I do not know the capacity of providers to be able to do this, but door-to-door services or outreach services would be useful. But of course, being extremely mindful of the social implications, such as triggering violence against women or GBV, triggering stigma and discrimination against some of the users, and also innovative ways to be able to reach out to the youth even when they are within those spaces. And then my second comment is a general comment. I think it is time that as a country, Uganda started to invest in medical research and medical innovations and productions for goods and services and equipment that we need without having to wait for it to be imported from somewhere. We have brilliant minds in our colleges. We have scientists who are trying out everything, but we do not give them the support they need, and that is an untapped area which we can use to develop Ugandan-based solutions, not only for SRH, but for our medical sector in general. Thank you very much.
Okay, lastly, we're going to have Sarah Patience, and then we give back to the panel.
Go back to my mute.
Hi, everyone. I'm Sarah Patience from Ireland. My sister Dorothy actually asked me to join and listen to this, and I'm really grateful. And something that really came to mind is, as all the panelists spoke, a lot that was really touched on that I felt was issues that supply chain has actually affected the different services, and have governance in a way have let down, but mostly because of lack of resources. So I guess my question around that, almost a solution, is a lot of conversation is targeted around, the youth and young adults. And if you really and I know someone spoke earlier on in regards to how are we going to reach people who don't have access to such platforms, and that is very important. However, there's a lot of youth and young people, college age or recent graduates or people in employment situations that are not. However, these are people I feel that greatly need to be invited to such platforms, because they're already on social media using their data on other things. And through that, you can reach and help people realize that there are people like you who are concerned about them. And that alone is a great way for people to break stigmas in their own minds, and also in the minds of victims who actually need these resources. But another question I really have is, how are we involving the policymakers? Because I feel like greatly on such panels, because it's such important information, but having them on such platforms to either take notes to address and return later would make a big difference. But from the panel and those listening, how are we increasing their presence in listening to such amazing webinars in order to resolve the issues that we're talking about and help us gain the resources that are being requested for?
Thank you very much. Given that we have only 2 hands, we'll give them an opportunity. We'll have Acheng and then lastly, Tony.
Thank you.
Acheng, Orero, and Tony, lastly. Acheng, are you there? Okay, let's move to Tony and then close the comments.
Can you hear me? Hello?
Yes, we can hear you, Acheng. Please proceed.
Okay, thank you. So my name is Acheng. I would like to thank CIHAD and the SISMOA Coalition for arranging this webinar. It's been very insightful into some of the very pertinent issues that the movement is facing currently regionally and in Uganda. So I'd like just to highlight that the organization I work for, which is Women's Link Worldwide, has done a compilation of the legal standards that African states and governments should be complying with. We've compiled all the guidelines, all the legal standards that are set out in various African instruments and all that, to be able to give us a platform on which we are demanding government to take action and provide services without refrain or without discrimination. We are in a situation where before even the pandemic, SRHR was at the bottom of the list for government. And now it's even, I don't know how much from the bottom we can go. So I'm happy to share this resource with the coalition as soon as this call is through. Thank you.
Thank you very much, Chen, and thank you for the offer to share the resource. We really appreciate. I know some of us had our questions already in the Q&A. They've been noted by the panelists, but also there are others in the webinar chat which have been noted. Then the papers that are available and have been presented, including the keynote address, will be shared with you. You can check the SISMUA and SRHR social media platforms as well as websites. You'll be able to access that, or even still reach out through the toll-free line that has been provided there to be able to access that information. So I'll now invite the panelists to speak in this order to respond to the comments, but also giving their concluding remarks. We'll begin with Dr. Carol and then go to Dr. Chigundu, Dr. Ernest, and then lastly, we are going to have Hope to give us the concluding remarks and response. Dr. Carol, you're welcome. Dr. Carol, are you there?
Hello?
Hello, we can hear you.
I'm sorry, I had an internet challenge. If you could recap what is required of me.
You're giving the responding to the questions that were raised and comments raised to you in the plenary, in the Q&A, as well as in the chat, and giving your concluding remarks.
Right, thank you very much. It's been an interesting conversation to have. I have typed a response to a particular question that was raised on supply chain. That question is really fundamental, and I don't think there's a straight answer to it. But overall, as the person who asked said, that COVID-19 has exposed that our supply chain for commodities generally, and in particular for SRHR, is really weak. And we need to be thinking how to engage at all levels to change this. My broad ideas were around data. One of the issues we have is we don't have enough data to understand the demand and the use of SRHR commodities. We need to have data as good as the HIV data, so that when you make the case for investment in SRHR supplies, you have your numbers to support it. The second thing I think is that we can expand our manufacturing in country. If CIPLA can produce anti-malarials, surely they can produce an emergency contraceptive. And this is also driven by our essential medicines list. We need to have a critical look at it. Products like mifepristone, misoprostol combination are not on that list, and yet they're essential. They decongest gynecological wards, and indeed they save lives. These products are on the essential medicines list. It will be easier to make the case for investment into those products. And I'm sure I don't have all the answers, but there's more that we can think about to engage to ensure that our supply chain improves. In closing, is to say that COVID-19, as I said, is unprecedented, but there are more opportunities for us than problems. And whereas our movement as people who advocate SRHR tends to be a complaining movement, sometimes you tend to achieve more if you focus on the opportunities and exploit them. And I encourage all of us in this meeting to think about what opportunities we have to advance our SRHR agenda and maintain our pressure on those, as opposed to being bogged down by what's not going well. Small quick announcement, all the Maristop centers are open and all of our service delivery channels are open. And as the lockdown eases, we are ready to receive and provide services, and we look forward to serving you. Thank you very much.
Thank you very much, Dr. Carol, and for also the information that you can access the services. Dr. Chigundu.
Hello.
Yes, we can hear you, Dr. Chigundu.
Okay, I thank you very much for giving me an opportunity to give some closing remarks and answer a few questions. I think not really answer, but give my opinion on door-to-door delivery. I think yes, we have challenges there. It would be that would actually be good for most of the preventive SRHR services, and but we still have challenges of low staffing, and I think we have to look there, and also the technologies of making people being able to access mechanically or by social media or whatever social services. I think we need to actually move to where these women are now that there's also stigma and also problems associated with real physical access by people to the facilities. We also hope that this lockdown probably will go down and release a few of these. Now the online consultations and treatment or management of cases, I think that's also a way to go. Some people can actually go through that, but we, like the lawyers sort of suggested, maybe we need to look at what does policy say. Are there any ethical issues that we need to look out for, issues of confidentiality? Because some of those come into play, especially in sexual and reproductive health services. But it's something that, for instance, me now, my clients are calling me and asking me questions, and I think if I had a way of knowing what whether it's right or wrong, it would be a good way of accessing some, making sure that my clients in Masaka and Masindi are able to access and continue with the sexual and reproductive health service delivery. As a closing remark, there's some definitely COVID-19 has been a wake-up call to the healthcare system and a wake-up call to all of us in our different coalitions. And I think we need to appreciate and begin to think outside the traditional ways that we have been providing sexual and reproductive health delivery, such that we are able to not to suffer terribly when we get physical barriers to service delivery. Thank you.
Thank you very much, Dr. Chigundu, for also enabling us to tap into our agency and power, that we can really do things differently, but also it's a wake-up call. We'll now move to Dr. Ernest.
Thank you, Salome, for giving me the opportunity to close out. I just want to first share with the people on the call and the panel and the attendees is that women and young girls have been ahead of us for a long time. They have been accessing reproductive health services outside the formal health system, and it's us who are catching up with them. So my proposal is, can we talk to the young girls and the young women and ask them what do they want? So IPAS has been working to develop user-centered design processes where we are talking to the young girls and saying what is currently happening. They have been accessing contraception, they have been accessing abortion pills on their own. I think our role is to come in and say, how do we improve their experience? So what we're doing is we've been undertaking research before COVID, and now we've had to accelerate the work that we've been doing in helping design programs that can help us package and provide services in a way that is safe. And like Dr. Jigundu mentioned, also address some of the policy and legal concerns. Because, for example, you cannot access some of these services without a prescription because they are illegal, but people are accessing them. So taking a public health perspective, that is harm reduction. How do we design services? And one thing to do is to talk to the young girls themselves and find out how do they want to get the services, how do they get information, how do they share. Somebody asked about the fact that many girls don't have cell phones. It may be difficult to reach them in the rural areas. Most girls, I'd say almost all of them, have friends. And for those that we've spoken to, they say they speak to their friends to get information. So being innovative means how do we create peer-led networks that allow us to share this information within these networks that is correct, that is accurate, and also circulate some of these commodities within these networks that can be provided safely. And this is some of the work that we're doing. So research is required, generating evidence and seeing what works. This is a chance for us to develop innovative telemedicine platforms. And when we think of telemedicine, let's not just think of fancy innovative things. WhatsApp messages that people are sharing, videos that people share, information that is spreading out there, and delivery platforms, border, bicycles, getting packages to women and girls out there. It's possible, and it's happening even on food. Let's reach them where they are with all kinds of services. But again, I want to repeat, are we talking enough to the young girls and women and young boys and girls and finding out what do they want, what kind of services satisfies them, and how can we as healthcare workers satisfy the service? Because I think the big challenge we've always had in the past is we design things for people and give it to them and they fail. So that's just the message that I want to give is let's do a better job of research that includes young people and young girls, amplifying their voice and finding out what do they want. Thank you.
Thank you very much, Dr. Ernest. Finally, we'll have Hope. Dr. Chigudu, can you mute your microphone? Let's have Hope. Hope, are you there?
Hello.
Yes, we can hear you.
Yeah. No, I agree with Ernest Nyamalo. Language is everything. It defines who we are. We need to be very, very clear about the language that we use and ensure that people understand it. What is SRHR? I mean, if we say it like that, people might not understand. But can we use a language that we understand within the coalition? Sorry, there is someone. And a language that, you know, other people understand. So one is language, it's everything. The second one is communication, and I think it's been touched on. Whatever we do, we must communicate with our constituency. We must have a power base. When we talk about SRHR, the tendency is for our government to say, oh, those are elite people, you know, ordinary people are not talking about that. Can we go back to our constituency, have a very strong power base that speaks out, so that it's not us speaking out, but the constituencies? We also need to move away from quick fix. Quick fixes don't work. Let's engage in the most difficult work of political conscientization, raising awareness, you know, ensuring that people really understand what it is and that they have rights and they can change. And I really do agree that, you know, women have always done these things and they have got ideas. We need to broaden the constituency so that it is a Pan-African movement. We need to make it political. We need to make it broader, because SRHR does not stand alone. It stands within broader socioeconomic issues. It stands within, you know, it has got a space within liberation movements. It's there, you know, it should be up there. We should not be ashamed of the work that we do. And we need to bring in other movements. How is it that when we talk about SRHR, you know, the first people, you know, that the first movements that people think about are women's movements? No, we need to bring other movements to support this, because I don't think that as a country we can move forward, we can make progress without understanding issues of SRHR. And we need to build a community. We need to build a community the way HIV and AIDS, you know, movement did. A community, or starting from the ground up to the regional level, up to the African, you know, regional level, so that there is a critical mass of people who can push for SRHR. And finally, we need to demystify issues of sex and sexuality. There is nothing mysterious about sex and sexuality. We will understand it. Let's talk about it, demystify it, be comfortable with it, talk about it openly, and then go forward with courage, with resilience, and with energy. And above all, we need to remain very, very, very drunk. You can't do this work if you are not drunk. Thank you, Salome.
Thank you very much, Hope. What a powerful way to close this webinar. We've all heard from the keynote speaker and the panelists, we can't do business as usual. We are not going to do business as usual. Otherwise, we should go and grow potatoes. It means to be resilient, we have to refocus ourselves. We have to get out of the comfort zones. It means we have to snap out of what makes us comfortable in terms of the work we do, who we engage with, how we engage with them, how we frame our message, but also who do we want to bring on board. We can't afford to continue speaking to ourselves and people that believe like us, but also we can't afford to continue having labels, those people, us, but really realize that this is our collective journey that we can travel together. And then another key area that comes out from all the panelists, we have to be at the forefront of both the national, regional, and the international responses, and how the COVID-19 response connects with SRHR. Because, like we all know, SRHR is always at the sidelines, and now it's further into the sidelines. So we can't continue sitting back. We have to tap into our own agency. And if you're not invited around the table, let's bring our own chair to that table, because we legitimately must belong to that table. And then we must assert ourselves in terms of longer term solutions. We are in a world that is called a microwave world, fast in, fast out. We can't do that around SRHR, because this is a huge component of our who we are as people, but also of our well-being and personhood as individuals. Therefore, we need to invest ourselves in longer term investments, but also things that are beyond just managing a crisis. And then engaging deeply and more meaningfully with people who are holding power and holding bodies, religious and cultural leaders, perspectives and norms about bodies and whose body does what. That is very critical. And then, of course, from a legal component, we need more guidance. And as a coalition, there's been recommendations here for us to look at an area of probably developing standard operating procedures on SRHR and COVID-19. How does that look like? Because it will increase services, but also keep our agenda out there. And of course, lastly, we need to consolidate the gains, while at the same time, we are aspiring to achieve more. With that, I'd like to really, really thank you for joining this webinar that has been convened by the Coalition to Stop Maternal Mortality Due to Unsafe Abortion. I'd like to thank whoever has attended this webinar and is not a member of SISMOA. I know people have attended from different time zones. You are really the people that made this webinar the way it is. Thank you very, very much. I'd like to thank the SISMOA members for A, attending, 2, for mobilizing your constituencies and networks to attend this webinar. It has been powerful, it has been exciting, but also we've had a number of people that are engaging both in the chats and also after this. I'd also like to thank my panelists. Thank you very much. You made us so uncomfortable. At one point in time, I said, I wish I am just a participant. I need to contribute to this. I'd like to thank Hope, our keynote speaker. Hope, you always make people so uncomfortable that they can't rely on their comfort for so long. Thank you for making us uncomfortable. Thank you for relighting our flames as activists, and more importantly, for challenging us to think differently. Lastly, I'd like to thank SEHAD and SISMOA for providing this space and call upon you to continue the space to interact, but also to look at issues that have been raised about inclusivity. Who is left out? Because this is a powerful and important conversation. And for all of us who are on this call, on this webinar, and are not members of SISMOA, please come and join SISMOA. We can no longer survive in a world where you're doing your own thing in your own way, because the work that we do and the issues we deal with are connected. And as Hope mentioned in the keynote address, there is what they call intersectionality. We can't afford to work separately and differently. With that, I'd like to sign out. Thank you very much. It had been a great time, and looking forward to being with you at the next webinar. Of course, apologies for running slightly late, but we'll try to manage that you can have your lunch. Go and enjoy your lunch, and let's meet another time. Thank you.
Thank you, Salome. Thank you.
Thank you.
Thank you so much to all the panelists. Salome, an amazing job. Hope we're getting drunk.
Thanks, all.
All right. Thank you, everybody, and good night.
Okay, hello, can you hear me?
Yes.
Yes, can you hear you?
Oh, well done, well done. Surely, Sehad, you unfair. I should have been a participant on this webinar.
I knew you were shifting and saying that.
I was so uneasy, I just wanted to type, but I couldn't type. Thank you very much, Hope. Thank you very much, Ernest. Thank you very much, Dr. Caro. Thank you very much, Dr. Chigundu. Thank you very much, Asia, for really, really, really giving this panel the teaching it needed. You all looked at things differently. I really enjoyed myself. The challenge I had was with time. Really managing time was difficult because when we are passionate about something, you also don't want somebody to end, halfway. So I want us to spend the next few minutes doing a debrief so that we kind of pick learnings, because Sisma said it's going to be a series of webinars and it will be important, but also to hear from our panel what you felt worked, what didn't work, but also how can we do better next time. So it's an open for whoever would like to share. So over to you. Dr. Ernest, Hope, Dr. Carol.
Job of coordinating and summarizing. I think that's one thing I haven't seen in other webinars, and that's a best practice. Actually, I'll even suggest to other webinars, having a host like you who understands the process and also summarizes and creates the process. And the nature of these things is that it was very hard to control time. So you did you did a very good job. And I think the way we set it up in terms of Hope starting off, then sort of building it up and having different, it wasn't pre-planned, but I think that was, it was, very wonderfully done. So for me, really, I think, given the fact that I think this must be I can't even count them, webinar during this period, I think this is actually the best one that I've been on so far, because it was very interactive, very well coordinated, and very well organized, and the different partners were able to bring in different perspectives and not keep repeating the same thing. We kept saying the same thing, but coming from different angles, which I found, very useful.
No, I want to agree with you. It couldn't have been better than this. That every piece built into another piece. There was a flaw. There was coordination. And, I was so amazed that happened. As you say, it was not planned, but that happened. And Solomon, thanks for wonderful facilitation.
Thank you very much. We've lost Dr. Carol. Can we have feedback from Dorothy and then the SEHAD team? Dorothy?
Look, where has she gone?
Okay, can we have a feedback from Grace and the people that are under that label host?
You can come. Thank you, Salome. Unfortunately, the other guys had also left, but Anne is here.
Great, Grace, okay, sure.
And you?
No, there was somebody that was still under the attendees. It's okay. Okay, Anne, please proceed.
Hello.
Yes, Anne.
Hello. Yes, I think for me to just say thank you for that good job done. I think it was a great discussion, and I think for once it's been quite powerful to call a spade. We haven't really gone around the SRHR issue. But kind of the discussion was pointing the issues out as they are, and that is I think a progress in terms of how we are framing issues and going forward as we work on issues that are a little controversial and contentious in nature. So yeah, for me, I think it was job well done, and thank you.
Thank you. Grace?
Thank you. You're going to hear from Dorothy.
Hello.
Yes, Dorothy?
Yes, first of all, I want to thank Salome so much for breaking the ice in terms of the introductions. I think it was brilliant. And then when Hope dived in, we all got lost in that journey. So it was brilliantly executed. We talked about the things that we always, shy away from, but it was so insightful. The panelists, the blend of the panelists made the discussions even richer. And the participation from regional to national to international, I think this just shows that this is just one of the kinds, and we've opened up a series of webinars, even post-COVID. This will be a spirit that we have to grow and nurture. So basically, I'm just thrilled it turned out well, and we hope that we carry on the learning, the interventions suggested by participants into full-blown realization of these interventions from the practical aspect of it, because there was so much coming in terms of how we can carry forward. So I look forward to realizing the advocacy opportunities that have emerged from this webinar and daring and getting drunk in this work. Thank you so much, all of you.
Thank you. Right. Thank you, Salome. On my end, it was a learning experience for me because I've not had a lot of I've not had a lot of experience with SISMOA, so this was a learning opportunity for me. On the technical side, I think things went as well as they could, despite the few technical glitches. But good thing is almost everyone we kept losing returned, so that was good.
Okay, thank you very much. Anybody else left out? Under host? Okay,
No,
on my
is
part,
it.
I really loved this webinar. I love the webinar. I love the fact that we had a cross range of panelists. I like the fact that we had a keynote that set the pace, but also tickled people into even reacting immediately. I think by the time Hope got to her third page, people were already writing in the chat. People were uncomfortable because SISMOA is around not making people comfortable, but really being uncomfortable so that we can be able to change things. So thank you very much for structuring this webinar in a way that it had a keynote, but a keynote other than somebody who makes you very uncomfortable, because that allowed us to really get out of those comfort zones and then know this is not the usual conversation. Hope, thank you very much for bringing your whole self to this process. Thank you for such a lovely paper, but also it's not academic. It is actually something an activist can move with. Thank you very much. And also, Dorothy, you thanked me for the introduction. Hope in the morning WhatsApp me to say, you need to introduce what SRHR is so that we don't spend energy and time. And so Hope thanks for that as well, because like we all see it set a pace, but also it didn't take us back in terms of when you start presenting. I'd also like to thank the fact that there was a focus, even if we looked at service providers, we looked at somebody who's providing services, the mainstream, that is Maristops. We looked at a frontline healthcare provider who is Dr. Chigundu. We also looked at the regional and international context, which is Dr. Ernest. Thank you very, very much, Dr. Ernest, Dr. Chigundu, and Dr. Akaro for really bringing your whole selves, but also at the end of it was all tying in to show that actually the challenges are universal. It doesn't matter the locality where we are. And so in terms of my recommendations to say moving forward, first of all, please make sure people have access to these papers, because we publish or people write these presentations so that people can share and get a feel of them. So please make sure that they are available, and also that the interventions that have been recommended are followed through. Because with SISMA, we have to make sure that we move. There's been powerful interventions follow up on in terms of SISMA. Lastly, follow up on whoever attended this webinar. We had 89 participants, and of those 89, send them a notice if they want to join SISMA, whatever it is, so that we do actually the being proactive, not to leave them to get through to us. Otherwise, people will go into the next webinar and they'll forget what happened here. So that is a challenge. I'm challenging Dorothy and Anne to make sure that you follow up with whoever has not been on this call, but also those that have attended, to explore whether they're interested in being part of this conversation moving forward. Those are my comments. I really, really enjoyed myself because I love SISMA and I love the work that we do at SISMA. Thank you for honoring me the pleasure of being the moderator.
Thank you, Salome.
Thank you.
Thank you. Thank you, Hope.
Bye.
Thank you, Dr. Bye. Bye.
Bye. Thank you very much.
I want